Hello, folks. Thanks for joining us on Head Inside Mental Health, featuring conversations about mental health and substance use treatment with experts, advocates, and professionals from across the country sharing their thoughts and insights on the world of behavioral health care. Broadcasting on WPVM 1037, The Voice of Asheville, independent commercial free radio. I'm Todd Weatherly, your host, therapeutic consultant, behavioral health expert, and with me today is a dear friend, Mr. Travis Herman, a healthcare consultant with Align Consulting Group here in our area in Western North Carolina, where he has been for a very long time. And, I don't want to say he's old or anything, but I would like to say that he is a man of great experience, that when I start to figure out and can't find a resource I need, a lot of times he's a man I'll call. I greatly respect his time and experience in the field. Mr. Travis, welcome to the show, and thanks for joining us.
Thank you. That's a great introduction. Appreciate that. Yeah. And it's a symbiotic relationship. Whenever I get in a pickle and I need a resource, I give you a call. So it works out.
Yeah.
Yeah. And I'm getting older, but I'm definitely a dinosaur in this industry, especially being kind of in the representative sales, world. Not many people hang around in that space for very long, and the ones that do, we're either gristled and burned out, or there's something inside of us that just keeps us trudging along, trying to help people, guide them to programs that make sense for them.
Yeah, well, you've certainly kept your vitality in the process of all that, and I'll add on to that the caveat that despite the fact that you channeled your role into outreach and business development, I know that you started like I did in direct care.
Mm-hmm.
And I can say, the thing that we run into, and I run into as a consultant all the time, is that you've got a lot of very talented providers out there. You've got therapists and doctors and psychiatrists and the whole nine yards, but none of those people really leave their area. So the number of people that really do know what's out there and get around and look at programs and have relationships and know people, it's a very specified role. A lot of times that's reserved for ed consultants. There are only a few business development folks out there in the world that I would consider like at that tier who really have been in the field long enough and have relationships that they can know resources even when it's not their program they're referring to. You are one of a handful of people I would rely on for that, and that is a major compliment coming from me or any consultant, frankly. So,
well, I appreciate that. Yeah, and you're right. The providers that are out there, very talented in what they do, but when they do have a situation where somebody needs a higher level of care, they only know what they know. They're not leaving their office to go tour. Well, very few practitioners leave their office to go tour programs, and so often
or can do it very much, right?
Have the availability, all those things. Yeah. And the ones that do, are the ones that are even trying to point people in the right direction. Often the things that they're referencing are either places they used to work at, which could have changed since they were last there, or it's a program that they've heard tell of, right? So they're kind of working off of old data, whereas
or very little data.
Part of your requirements, to do what you do, you're required to visit programs every year, every 2 years, a certain number. And then for me, I did it, one, out of curiosity, but two, as we try to find partners, because we're not, Lakeview Health isn't the right fit for everyone. So if I don't have I'm going to date myself, a Rolodex, right, of options that check more boxes than my program does for a particular person. If I don't have that, then I'm really not that great of a resource. I can talk about my program all day long, but if I've got a family on the phone and we've walked through some conversation and realized that we're not the right fit clinically or geographically or financially, I could hang up the phone, right, and end the conversation and say good luck, or I can say, hey, I know how much time and energy it took to make this phone call. Let's pivot and explore alternative options that might be a better fit for you or your loved one. And that's actually the fun part.
Yeah, yeah, absolutely. Well, I mean, in reference to that list that you're talking about in terms of fit, obviously you talk to a family, you talk to somebody who's in need of care. We're talking about, what therapeutic need, what kind of programming do they need? And, what is it? Have they got anything specific you need to address? Is there a medical concern? Is there specialized psychiatric concerns that are part of their profile? Is our
Right.
program capable of meeting it? But one big ticket item that you and I were talking about before we started our interview today was the what does it cost and does it take my insurance?
Right.
And is it first? Sometimes it's first for families, It's like, look, we got to do something that's right, but we also got to do something we afford. And, you were like, we should, I mean, this field in the last decade, you walked into it, you were telling me in 2008, the difference between the insurance game in 2008 in addictions care, substance use care, and mental health care versus today it's like night and day. It's still not where we want it to be, but it's well ahead of where it was.
Oh yeah,
But it's
absolutely.
still so very tricky to navigate. And you end up in all kinds of scenarios. So you were offering graciously to talk because I think that you spend actually even probably more time doing this than even I do, and I spend a lot of time doing it. I would love to hear what you've got to say about how to navigate that piece when it comes to finding good treatment.
Yeah. Well, hey, I appreciate that. Yeah, I would love to spend some time on that. And typically, s- sometimes it's first if the person I'm talking to brings it up out the gate, and I just address it head on. I just say, when they say how much is it going to cost, I say that's a fantastic question. It really depends. It can be literally
Everybody
a
hates that
hundred
answer.
dollars, right? It could be $100 for 30 days to 60 grand for 30 days. So let's kind of start at the beginning. And often what I'll do is I'll tend to spend 15, 20 minutes with folks asking them some very specific open-ended questions to just get an idea of what's happening. Um, give me some examples of what's going on in their life or the loved one. How long has it been a problem? What have they tried? Have they gone to treatment before? Did it work and to what degree? And when I say did it work, I'm not trying to be cheeky. It's just, did someone go to treatment and have a period of mental health symptom reduction and stability or abstinence or reduced use? Was there some sort of stability or not? And for how long? Um, and then I'll ask them, sometimes depending on the type of person I'm talking to, I might ask, how much do you think that process has cost you, or what do you think the consequences have been for, going this way or that way, or not doing anything, or not trying anything. And then I try to ask them, how do you feel about that? Like, what is your, you've described to me what you're struggling with and what's going on. How do you really feel about it? And often most folks say, I'm really frustrated and upset, or a family member might say, I'm really scared and I don't know what to do.
Or I'm
And then
hopeless
I'll
about this
ask,
because I keep running up against a wall, right?
yeah, right. I've tried everything and nothing's worked. And then I typically ask them, are you willing to walk with me um, to see what a solution might be? Have you kind of given up trying to deal with it on your own and willing to have a conversation? And by this point, they say yes. So then the next thing I ask them, I say, hey, a lot of folks want to talk about the time,
Mhm.
the energy, and the money it's going to take to um, support your loved one or help you through this process. Which one of these do you want to talk about first?
Yeah.
And then I just start with which one they start with. If it's time, I'm referencing how long you might be in treatment, how quickly you can get to treatment. So I try to give them some time parameters. And then energy, I'm referencing, how much work it might have to take, a phone call, a flight, a car drive, or
Fill out
a
this
letter from the
form.
probation officer. Yep.
Hmm.
But then the big one, and sometimes it's first, but sometimes it's last because people get uncomfortable around money, depending on how they're raised. Um, they'll say, I want to talk about the cost, and then that kind of brings us into what we were just talking about. So before I even talk about money, I try to do a lot of this information gathering prior to, so I can really understand as much as possible kind of where we're at, what has been tried and what hasn't been tried, um, so that we can have a broad conversation about cost. So to that point, uh, just because you have more money than God doesn't mean you need to spend it all, right? And just because you have Medicaid doesn't mean that there aren't any options.
Right.
So if I've done those questions prior to, that prepares me for, if I've never asked, if I don't ask what have you tried before, I may offer a suggestion that either they've already tried or they just don't have the resources for because they have tried these things and now they lack resources. So I went a very long-winded way to get to the question about money and
Oh,
insurance.
I think you're talking about profile, giving, which is why, I mean, I know that you get this. I certainly do, which is the occasional text message or email message like, "Hey, I got a friend or I got somebody that needs X. Have you got a couple of programs?" It's like,
Yeah.
well, no, actually. Can you
Yeah,
maybe
yeah, I've got a
what's
million
their
of them. Let's
what is their
right.
gender, first of all? Let's
Yeah.
maybe
How
start
do they
with the
identify?
basics. Right. How do they
Uh,
identify? What's the issue, et cetera, et cetera? And like it, it's not enough to try and address somebody's questions or their needs with just one, channel, money,
right.
program, etc.
Yeah.
You got to have a profile so you know where you can land and what questions to start asking. If they're
Yeah.
on Medicaid, it's a whole different set of questions, different
Well,
from a person who's
correct.
using private insurance or is ready to private pay all the way through to the hilt if they need to. So
Yeah.
those are very different profiles of people.
And if you're on probation and can't leave the state of North Carolina, then it really doesn't matter what exists outside of the state of North Carolina,
Well, you can. They don't like it.
Right.
But it's going to take you a lawyer to get there. But sometimes you can leave the state of North Carolina. Usually you cannot, or they don't want you to for sure.
Right.
I've had a couple where I've been able to pull it off, but yeah, absolutely.
It all depends on that probation officer and how much legwork they want to do,
That's
at
right.
least in my experience. So to that point, right? So if we just answer the question or just answer the text, we could really do some harm. We could make a recommendation with very little information, and it could really be a bad fit, right? Um, Same thing with Lakeview, So if somebody calls me and we're looking at Lakeview as a potential option, ultimately, I'm not just saying this because it's the correct thing to say. I really want to bring in a patient that we're a good fit for, and I want that patient to also be a good fit for us. It doesn't. I've been doing this long enough, and I've seen enough round pegs shoved in square holes, that to know that it rarely works out. And there's a lot of programs that, um, and this isn't a judgment thing. It's just kind of the way the system works is, um, folks get, not enough questions are asked and somebody comes into treatment into a program that's not a good fit for them, or they're moving too quickly, or they're bound by some insurance components, and their options become really narrow really quick because we didn't do the legwork, we didn't ask the questions, we didn't trust the process that if we're not the right fit, maybe there's a better option.
Let me, if I may, so these are some of the barriers that I run into, and I would love for you to elaborate my list a
Mhm.
little bit, if you
Yeah.
can. You
Yep.
probably can, but so it's like, all right, let's start this insurance. Let's start asking the insurance question, and let's start figuring out what it is. It's like, okay,
Right.
what state are you in?
Hmm.
What policy is it?
Yep.
Is it, who does the policy belong to? Maybe it's a Blue Cross Blue Shield, but it belongs to some other managing entity, or maybe it's an employer that's managing it itself. There are a
Yeah.
lot. Maybe
Or the behavioral health benefits are carved out to someone else.
correct, right? They're
Yeah.
being offshoot. Do you have out of network benefits? A
Hmm.
lot of the private pay entities or high quality facilities are out of network. Not all of them, but a lot of them are. So you need an out of network benefit. The other barrier I see is people don't have a residential care benefit. They
Yeah.
they they will pay for PHP and IOP, partial
Hmm.
hospitalization or intensive outpatient for those who don't know what those are, but
Yeah.
they won't pay for residential, or they'll only pay for residential. Let's say, to you and me, when I hear residential, I think 60 to 90 days.
Yeah.
When you're dealing with an insurance company at 12 days of coverage, they're going to start calling, hey, are they better yet?
Right. Yeah.
And then, the rest of the barriers are, what's the out of pocket going to be? What's the
Yeah.
percentage of coverage for a mental health or addictions care? If it's a primary mental health kind of issue, and the person doesn't have any co-occurring substance issues.
Yeah.
Now, correct me if I'm wrong. Lakeview, are you guys dual license now? Is that true? Did I
So,
understand that to be true?
yes. So we have a special waiver in the state of Florida to provide uh, primary disordered eating treatment in our women's program. So
Okay.
so we have a licensed mental health license specifically for eating disorders in that women's program that will be coming online um, in spring of 2023.
Great.
2020.
Well,
But
that's good for me to
we're
know.
licensed primary addiction, but we serve mental health co-occurring. But that's a difficult one to explain too.
Right. So here we're and I there's a therapeutic side of this, and I would say
Mhm.
that an addictions issue at the level that needs residential treatment is a mental health issue. I would argue that.
Absolutely. Yeah.
Insurance companies do not feel this way. You've
Correct.
got two different versions. You've got primary mental health diagnoses, and you've
Yeah.
got primary substance use diagnoses, and you can have those co-occurring, but they look at them as independent. So if you're going to
Right.
go to some place that's an addictions treatment place and you don't have a primary addictions diagnosis or issue, they're not they're they even if they're appropriate to treat you, your insurance company's not going to pay for it because
Right.
you don't bear the diagnosis that is appropriate for treatment at that
Right.
particular facility and or your coverage. And there are some plans that don't carry a primary mental health treatment benefit. They will
Hmm.
carry an addictions benefit
Yeah.
or a substance use benefit, but not a primary mental health. So, one thing that we're seeing in the field is that we're seeing facilities dual license so that by the term that person finishes, quote unquote, right, their
Yeah.
residential treatment for substance use, they can now begin residential treatment for
Yeah.
primary mental health. And they can
Yeah.
carry that out in order to get more days out of their coverage.
Yeah.
And then you run into the rest of the stuff, which is, you've got your in-network Blue Cross Blue Shield, but it's Blue Cross Blue Shield of Florida and not a California, but not California or Tennessee or North Carolina or whatever it is, or it's
Yeah.
managed by this entity, and that entity doesn't recognize this list of providers that's in network, or all these kind of really drilled down specific aspects of coverage, which is why you have to say, well, it all depends. And then finally, what rate they're going to actually reimburse you at for this level of care.
I think you hit it all, man.
Did I get
That's
it?
it.
I mean,
I mean, you nailed it. So in I mean, you listed. I mean, I lost count. 20 barriers, all related to just insurance. Gone are the days. I mean, I still get a occasional phone call where the person on the other end of the line is. I'm from North Carolina, so I can say this. So, but typically it's a Southern fella that says I got good insurance. Well, that doesn't really exist anymore.
you did.
Uh,
The accent was good too. You nailed it.
hey, that's my hometown. Um, but you're right. And whenever I describe navigating and we'll stick to insurance, but just to broaden it a second, going back to options. So if you have $0, zero insurance, right? There are resources for uninsured folks. And North Carolina is one of the unique states that actually has options for that. And there's grant programs and work programs, and there's options there. So if you have nothing, you do have options.
No options.
And then there's a category where if you have Medicaid, North Carolina Medicaid, there's options there. Just a little caveat there, Medicaid rarely crosses state lines. There are some specialties where you can go across state line to get a specialty thing. But in general, North Carolina Medicaid stays in North Carolina Medicaid. And then there's another column, which is Medicare. We could do a whole podcast just on Medicare,
Oh my gosh,
A,
right?
B, C, D, Advantage plans. Just so you know, there's no addiction benefits in Advantage plans. Medicare is only accepted for inpatient residential, can only be accepted at a hospital setting. So there's limitations there.
And there are especially Medicare plans out now that are paying for residential care, but you have to apply to be part of them.
I
have only become recently aware of this because there's a program that's accepting it in North Carolina. Another facet of this complicated thing that we're talking about. So.
I've learned something today. I haven't heard that one yet. So, but it's its own little verdict or
right.
Column.
It's
right.
A box. It's another box, right?
And then you have commercial insurance with all the bugaboos you mentioned, and then there's the self-pay. And self-pay is sky's the limit. I've seen there's technically residential programs in North Carolina that cost $2,500 for 28 days. And then there's programs and really good programs that are throughout the country that are 60 grand for 30 days. So
right.
Cash pay is a whole other bucket.
Yeah.
So we've I'm speaking to a loved one, or I'm speaking to a person. I've walked through these questions. I ask them, time, energy, money, which one are you going to talk about? And they say money. And then they say, I'll say, well, tell me a little bit about your resources. Do you have commercial insurance? And so if they say yes, and they use kind of your bigger names that we know in insurance, so Cigna, Aetna, United Healthcare, Blue Cross Blue Shield, those are all the main players. There's some smaller players, Friday Health Plans, MedCost, Health Smart. There's some other things in there, but the main ones that you see are those ones I mentioned first.
And then there's the level of plan. Maybe it's a gold or a silver or a platinum, or whichever.
Tier 1, Tier 2, gold, platinum, or a state. So the case I'm working on today, or person I'm working with today, has Blue Cross Blue Shield of North Carolina State Employees Plan.
Right.
That don't mean that is Blue Cross Blue Shield of North Carolina. That's just the manager of it, but the benefits can be completely different than if you bought Blue Cross Blue Shield off of the marketplace. And then you have marketplace plans, and that's a whole nother thing. So Lakeview Health is in network with Cigna and Aetna, but we're not in network with the marketplace plans.
Well, and I'll tell you this is something I've run into as a barrier through all of this. We still have yet to identify, but marketplace plans are HMOs, and they don't carry out of network benefits. And if you look at their provider list, their provider lists are not extensive. And, a lot of times if it's a, provider list for the state of North Carolina or South Carolina or Florida or whatever, it's usually limited to that state with some, occasional at the line crossovers. And so your provider list, or it's a provider that is in your area but has a national presence, like in hospital settings, for example.
Yeah, sure. Yeah.
So you run into this. It's like I've got a client right now. The person's in their 30s. The person who's in need of care is in their 30s. The parents are like, "Hey, what do we do?" I said, "Well, it'd be good for him to have insurance." It's like, "Well, maybe we could just jump on and get marketplace." I said, ideally, I think that in the long run, yeah, sure, a marketplace plan is going to do you well because you want him to have health coverage. But if you're doing this in order to specifically help you pay for treatment, mental health or addictions treatment, you're not going to find a lot of choices that are in network, and they don't have an out-of-network benefit. So if you're going to this facility, it's probably going to be out-of-network for you, and you're going to get zero back on that investment. So please go to a broker and buy yourself a private market plan.
Yeah. That actually might have been the case that we both were working on
I
this
think
year.
you're right, actually.
Yeah. You got somebody with Anthem, Virginia, right?
Right.
HMO policy, your only options are in Virginia. But if you're struggling with addiction and your use is predominantly in, the place that you live,
Mhm.
and then you're restricted to the state that you live in, it can
Not an
become
ideal
really
scenario.
difficult. Yeah. So what do we do? Right. So just because you got insurance doesn't mean we've got a silver bullet here. Um, so what I do is, well, where we start is, so I've asked them, do you have commercial insurance? They say yes. They say I have, one of the ones mentioned, or some other, and I'll say great, fantastic. And they'll say, do you take that? To which point I say, typically yes, or we have worked with it before. However, just because it says XYZ name on the card doesn't mean that it's a slam dunk. So what we actually like to do is collect your name, date of birth, your insurance information, and then what we will do is called a insurance verification or a verification of benefits.
VOB.
And so, yeah, VOB. There you go. And what that essentially is one, we're confirming that this plan is even active. And some people don't even know. They're not trying to be deceitful. They just really they thought they had it.
They didn't
Oh, I
realize it
forgot to.
lapsed last month.
They did.
And
Yep. Especially when you're dealing with, I mean, you work with a lot of young adults, like the 25 to 30-year range where you're no longer on the parents' insurance.
it's
So somebody else
limbo.
isn't paying premium. Yeah, premium. You're supposed to be in charge of the premium, but you've been, experiencing mania for the past 4 weeks, or
Or in the hospital.
you've been in a hospital, and so you may not even know where your insurance card is, much less whether or not the premium's paid. So that verification benefit to confirm is the benefit plan active? When does it renew? That's another barrier, right? So we're at the end of the year, so most insurance plans restart at the first of the year. So what that means is if I pay my deductible and out-of-pocket max today, December 1st, and I'm in treatment 32 days, I'm going to have to pay my deductible and out-of-pocket max again January 1st.
January 1. That's right.
That's crazy.
And of course, that because I keep getting reminded by, various things that December becomes an enrollment period for people.
Mm-hmm.
Like September's an enrollment period. Sometimes you can qualify for special enrollment if you've lost your insurance and they can get you in
Yep.
on a plan. The other thing I'll throw in there is that occasionally, I know that you guys do this and have before, in my experience at least, is negotiate a single case agreement, which
Yes.
is to, even if you say you're not in network with the insurance, or the provider is not one that you've worked with in the past, but you can reach out to them and say, hey, we think we're the right provider. Let's pretend that we're in network with you guys and
Yeah.
negotiate a rate around it. And that way
Yeah.
that can get people down the road a little bit. It's a trick. It doesn't always work, but it is something to keep in mind, and certainly something to bring up with insurance companies. Out past all of this that we're talking about, you start to finally get to you've run the verification of benefits for the family, and you finally get to the out of pocket
Mm-hmm.
piece, which
Yeah.
there's probably going to be some. There are a few cases where people are getting, 100%, 80% to 100% coverage. They exist.
Yeah. Yeah.
But otherwise, people are coming away with some out of pocket and probably some amount to pay up front.
Mm-hmm.
Let's say that that's an amount that's going to be challenging for you to navigate. What resources are you pulling from, Travis, to like help families, handle the payment amount that they're going to have to face?
Yeah, that's a great question, and I appreciate you asking it. So there's some rules, right?
Yeah, totally.
So a couple things. All right. So out of pocket max. So let's say we run your benefits. Uh, well, let's walk through two scenarios, right? So let's say we're in network with Todd Weatherly's insurance. Uh, Generally, what we are collecting coming through the door, and when you're in network, it's an actual contract with that insurance company. We have a contract that says we're going to bill X amount of dollars and we're going to get paid X amount of dollars, right? That's the contractual component of it. And we say that we're going to collect the deductible and out-of-pocket max, in addition to billing, that rate, that agreed upon rate. So what we're going to collect is that deductible and out-of-pocket max. You, as the member or policyholder, your agreement with that insurance company is that you're going to pay that deductible and out-of-pocket max. That's your portion, right?
Right.
And that's different depending on what level of insurance you purchase. Now, here is the
deductible, out of pocket max, and there's out of pocket max, and there's the co-insurance.
yeah, so
right, right.
There's a co-insurance, right? So when you're in network, there's no flexibility from the facility side of what we can or cannot collect. We're contractually bound by that. Now, we could do a payment plan. So when you talk about resources, we can walk through with our billing department what is possible for the family to pay, and so we can do a payment plan on those collections, but we are required to collect it. Right now, additional resources, whether it's in network or out of network, there are some nonprofit scholarship programs out there. They change from time to time, so I don't have an active list of anything, but there are some programs out there that can help families subsidize.
A lot more for adolescent care than adult.
Yeah, that's often the case. And then there's some specialty scholarship programs for like specialty populations. So first responders have a lot of support these days. Veterans have a lot of support these days. So there's some scholarship funds available to assist that person with covering some of those deductible and out-of-pocket costs. Now, we can't, as a provider, it's illegal for us to subsidize that or pay for that or waive that. So we are contractually bound to collect it, or attempt to collect it. I mean, if you can always not pay me, or you can give me a fake credit card, or but we then have to walk through a collections process, and that just gets really sticky. But we're contractually bound to collect that.
Clarify this for me real quick, Travis. Now I'm aware that medical expenses, you can't be, even if you don't pay, let's say you don't pay your medical bill to the hospital, they can't put that on your credit, because
correct.
Credit can't go on your medical expenses. That include the treatment, the addictions treatment industry as well, mental health and addictions treatment industry.
As far as I'm aware, yes.
Okay.
Yeah, it would just ding your credit. Or no, I mean, it wouldn't ding your credit.
You call a collections agency and you're going to try to do that. You're going to try to collect, but
yeah,
right.
I mean, I can't, we can't track you down and send people after you. Right. Yeah, but I mean, and so we're at risk too, right?
Right.
So that's generally what happens with in network. Scenario 2. Todd Weatherly has an insurance that Lakeview Health isn't in network with. And, let's say you're on your spouse's policy, and let's say we're going to do 2 scenarios on that. So let's say it has out of network benefits and we are out of network. Well, then we have a little bit more flexibility because there's no contract. We don't have a contract with that insurance company. So we can be a little bit more flexible with the payment plan. Now, we still are required to collect, but we can be a little bit more flexible just on how much coming through the door and length of payment plan and that sort of thing, because there isn't an official contract. So that's an option. And every company does a little bit different.
The one barrier I see people run into with the insurance companies on that end is, okay, they have an out-of-network benefit, right? But insurance companies, this is going to come as a shock to everyone listening, but they will try to deny you coverage when you
when you're out of network.
Just when you're out of network, they're going to try to deny you coverage. So if it's out of network, you have to do a little more fighting for it.
Yeah,
and it's a bit more of a battle. There are,
that's a good point.
back to the payments. There are companies that have, you can that will loan you money for medical
Mhm.
expenses. There's a couple of them out there, and then on the other side of that, there are also claims denials management companies out there that will help you get more from your insurance company after they've denied your claim or haven't paid you as much as you thought they should. Those companies exist out there as well. I
Yeah,
assume your other scenarios, if they don't have an out of network benefit and their leverage
yeah,
decreases rather significantly in that scenario.
correct. Yeah,
not
it,
not impossible. I mean, it's been done, but it's not
it's
easy.
been done, but it's harder. And really quick on the out of network process. Often the deductible and out of pocket max is higher. Typically, it's double, but I've seen it be. I've seen
Right.
unlimited out of pocket max, which basically
Oh wow.
means you can go out of network, but you're essentially cash pay, right?
Right.
There's not even any point to use your insurance because it's you know the there is no limit to the out of pocket max payment. So it's really uh, the terminology is even incorrect. Out of pocket max, there is no max. And I was going to go somewhere with that. Oh, so so typically if you're, let's say you're in network, we're in network with your insurance and your deductible is $2,500 and your out of pocket max is 5 grand. That typically is the way. It's not always that way, but it's typically 25, like a one number deductible and then double that for out of pocket max. And then out of network is typically that out of pocket max for deductible. So $5,000 deductible, $10,000 out of pocket max. That's generally what you see the trend as, but those aren't fixed numbers.
Right.
So you can come to Lakeview Health out of network for 10 grand in that scenario, or you could go in network somewhere for 5 grand, but it may not check all the boxes you need or want.
Right.
Um, and we view the out of pocket max as your out of pocket max. Like once like that term is exactly what it means. This is your maximum out of pocket for you. Anything above and beyond that is between us and the insurance company. Uh,
For your length of stay, unless, like you say, you're sitting in December
yes,
and you
correct.
and you've
And
got
then
a
we
30
restart the
and
clock.
your clock resets when you hit January 1. The other
Or like
one,
my former employer, where the benefits reset in 1st of September. So it was fiscal year,
oh,
like
brutal.
So then those do happen occasionally, but most of them are annual. And uh, the other thing I was going to add on that was out of pocket max. Oh, there are companies that do what's called balance billing, and so if the program is 60 grand and your insurance covered 30, you're on the hook for the additional 30. We don't do that, but some companies do what's called a balance billing. So they're covering all their costs.
Our program is 90 days. This is what we've checked your benefits for being.
Right.
This is going to
Your
be the
benefits
total
will cover
cost,
this. The remaining balance is
and
this.
we're going to
Yeah.
need that. Yeah,
Yeah.
there's a program out in Texas that does it that way. Though you can ask to pay, the whole amount, but let me
Yeah.
pay it in three chunks or whatever.
Yeah.
The only
Well,
other
the same thing happened when my wife and I had our child. I mean, that was
oh
that
wow,
was
yeah. Hmm.
essentially how it happened for us. This is the total cost. This is what we project your insurance covering. Um, Also, by the way, your deductible restarts in the middle of this,
In the middle of this.
pregnancy. Um, and they
Oh man.
also, but what they did, because you have 9 months, you don't have this in the addiction world, right? You can start paying towards that throughout that 9 month period, or eight
Right.
months, or however
Okay.
long it takes for you to figure out, right? So they can do a payment plan, but that's essentially a balance bill.
Yeah, usually the company, the provider, that is the treatment company, is the one that's if you're going to pay balances, then they're going to do that for you, not your insurance
Right.
company in that scenario. The only scenario I can think of that we haven't covered yet before we run out of time here is which we run into a lot with adolescent and young adult treatment and wilderness. Wilderness
Hmm.
in the state of North Carolina and in most places, with a couple of exceptions, is the wilderness program can't be deemed residential, so they can't license themselves residential because you don't stay anywhere.
Right.
You're always roaming about.
You're
There's
roaming in
no
the woods.
place to license. Therefore,
Yeah.
they have to, sometimes they'll have PHP offices and they can do it that way. But what they're giving you ultimately is they're not billing your insurance for you. They're sending you a super bill. So for every therapy session and group and whatever else, all therapeutic care you've received, they send you this super bill that shows you all of those and the billing codes and how much. But a lot of times for a sixteen to $20,000 program, you're coming away with about $8,000 worth of billable fees, and you're going
Yeah.
to get about half that back. And it's and it ain't great.
Right.
But that's the only scenario I can think of that we haven't covered yet. So if an insurance company's not, or excuse me, if a provider's not going to, like, well, we don't bill insurance and everything else, and they don't say that they provide a super bill, you can ask for one. So that's something you
Yes.
should do.
Correct. Yeah.
Right.
That's always really helpful. And when I've seen people do it, it's a pretty laborious process,
Oh
but
my gosh, it's terrible.
it can be done. And then the no out of network benefits, that kind of falls back into your HMOs, your EPOs, or the behavioral health benefits are carved out to a really narrow network.
Mhm.
And then you're basically forced into your only option if you're going to use your insurance is whatever that insurance company says your network is.
Right.
And sometimes that it can there could be some options in there, but often they don't check all the boxes you're looking for. Or, you know, you're in school in Oklahoma and your parents got you,
The school plan.
Anthem,
Right.
Virginia, and your only options, in that EPO HMO policy is back in Virginia. Well, you're in Oklahoma in the hospital. Like, I mean, come on,
Right.
how do we get
Work.
there from here? So,
Yeah,
um,
it's a complicated system. I think my advice to people is find somebody who knows what they're talking about.
yeah. And
Um,
some days that may not be me. When
yeah.
when insurance stuff changes, I mean, I'm learning every single day how to navigate this. And what I do right now for Lakeview is I specifically work with our corporate relationships and working on the employer employee side to help the employee understand their benefits, help the employer uh, help employees navigate those benefits.
And get the
Uh,
care they need all the way through, not just a
yeah,
portion of it. Right.
right. And get well and then come back to work.
Yeah. I think that the thing at the end of all that is, as people look at this, and you've seen people I mean, they're going to refinance the house and they're going to do all these things and end up with a lot of expense. And maybe that's worth it. I mean, it's possible that it is.
Mhm.
But I would, where you started with this was building a profile for a person and understanding where they're coming from, including the willingness of the person to engage. Have they been in treatment before? Was it successful? How do you feel about it? Like, how are these things? They're important because, I tell people find the right thing to do and do it for long enough. Just like
Mhm.
any form of
Yeah,
care, you need to do it for the prescribed amount of time. That amount of
yeah,
time is not dictated by an insurance coverage. It's dictated by the providers that give it.
yeah,
So you're there for a result, not for a period of time.
yeah,
And if a person's unwilling to commit to that, if they're unwilling to do all the pieces about it, I would stage my level of financial engagement per the scenario that you're faced with, and take it a step at a time. And get people involved who know what they're talking about. So you go in armed with good advice and good information. I mean, I'd say that about anything, but definitely about this.
absolutely. And we didn't even touch on it. We can do a part two criteria. You know, uh,
Oh man,
there's a
yeah.
whole level of criteria that is involved in this
So when
insurance
we
based
when we
on.
part two this, we're going to do admissions criteria for residential treatment. That'll be our next one. We've navigated the insurance, and now we're going to go for the clinical side of this equation.
That sounds
Travis,
great.
thank you so much for joining me. I'm really happy I had you here for this topic. It's good to have somebody backing me up with good knowledge. I always learn something when you're here. Thanks for being with us, folks. We'll see you next time.
Well. lost in here. I need to find my way home. I feel so lonely and lost in here. I need to find my way home. I feel so lonely and lost in here. I need to find my way home. I feel so lonely and lost in here. I need to find my way home.